Welcome to ATCM, the Emergency Medicine channel. So,
Yes.
A 72-year-old female, known case of CA breast, presented to the ER with acute onset breathlessness. On our initial 10-second assessment, patient was confused and tachypneic. Coming to primary survey, airway was patent, no pooling of secretions, no hoarseness of voice, no stridor. Coming to breathing, air entry bilaterally equal, saturation of 76% in room A. At this point, we started on oxygen 9 liter with face mask. Respiratory rate was 35 per minute. Coming to circulation, BP of 70 by 50 millimeters of mercury and heart rate of 128 beats per minute. Two large bore IV cannulas were inserted at this point of time and we started on IV fluids. Coming to disability, E3, V4, M5 and pupil bilaterally equally reacting to light.
When you tell IV fluids, you have to exactly tell what IV fluid you have started. That is very important. IV fluid means it can be DNS, 5% dextrose, normal saline, ringer lactate, anything is okay. But here, which IV fluid you have started, that is very important.
Started on a normal saline.
Normal saline.
Coming to exposure, temperature of 98.2 degree Fahrenheit and GRBS of 130 milligram per deciliter. Coming to adjuncts of primary survey, ABG was taken showing a pH of 7.316, PCO2 of 44, PO2 of 50.7, bicarb of 22 and lactate of 5.5, indicating a type 2 respiratory failure. ECG was taken showing sinus tachycardia and S1, Q3, T3 changes.
Can you expand what is S1, Q3, T3?
Sir, in lead 1 there is deep S wave and in lead 3 Q wave, deep Q wave and T inversions.
What is the difference between S wave and Q wave in ECG? How do you differentiate?
First positive wave is the Q wave, sir.
First negative wave is Q wave.
First positive is R wave.
First positive is R wave. First negative wave is Q wave. Second negative wave is S wave. Okay. So S1, Q3, T3.
A point of care ultrasound was done at this point of time, which showed severe LV dysfunction and RA-RV dilatation, no regional wall abnormalities, no clots bar effusions. Chest X-ray was taken and that was found to be normal. CBC CRP point of care showed a total count of 4000, CRP of 8. Coming to sample history, a 73-year-old female, known case of CA breast with multiple meds on palliative chemotherapy and radiotherapy, and also known case of hypertension, dyslipidemia, CAD, complaints of breathlessness since today morning. It was acute onset, progressive and corresponds to NYHA class 4. No history of any fever, productive cough, chest pain.
Can you tell me what is NYHA classification? Where all it will be useful?
New York Heart Association classification. It is used to grade breathlessness, dyspnea.
It is useful to grade even chest pain, breathlessness, all cardiac symptoms you can grade. It all depends on whether the breathlessness, palpitation, chest pain all increases with the exertion or not. That is most important. Exertionally, if breathlessness or palpitation or chest pain increases, then the grade increases. So grade 1 is?
No limitations of any activity.
For unaccustomed work, patient develops symptom. Grade 2 is?
Mild symptoms.
Accustomed work, he is developing symptom. Grade 3 is?
Moderate symptoms.
Moderate light is for routine activities. You are combing, taking shirt, going to bathroom. That is routine activities. Grade 4 is?
At rest.
At rest. Okay, so at rest is most severe. Okay.
No history of
unaccustomed work, accustomed work, routine work, and at rest.
No history of any hemoptysis, recurrent pneumonia, recent surgery or trauma, previous history of any DVT or pulmonary embolism, no history of any oral hormonal therapy, no history of any unilateral leg swelling, no history of any drug allergies, no history of any similar episodes in the past. Coming to general examination, pallor was present, no icterus, no cyanosis, clubbing, generalized lymphadenopathy, pedal edema was present. Coming to respiratory system, normal vesicular breath sounds, no added sounds. CNS examination, E3, V4, M5, pupil bilaterally equally reacting to light, moving all four limbs. GIT was soft, non-tender, and bowel sounds were present. CVS S1, S2 were present, and no murmurs were present. So our initial diagnosis was massive pulmonary embolism secondary to disease progression or malignancy.
Okay.
At this point, we have calculated the
What was the primary malignancy?
CA breast with multiple necks.
Much. Okay.
So according to the latest criteria, we will classify pulmonary embolism as massive, submassive, and small to moderate.
Okay.
It is basically classified based on 4 parameters: clinical examination, RV dysfunction, biomarkers, and on imaging whether we see a thrombus.
Okay.
In clinical examination, hypotension, if it is present, it is indicative of massive. It is absent in submassive and also moderate.
Okay.
RV dysfunction is present in massive and also submassive, absent in moderate. And biomarkers NT-pro, BNP, and tropo elevation is present in massive and submassive, absent in moderate pulmonary embolism.
Okay.
And the imaging which shows CT or echo which shows evidence of thrombosis is present in all the 3 embolisms.
Okay.
And in massive embolisms, the management of choice is thrombolysis unless it is contraindicated.
Okay.
Whereas in small or subacute case, the investigation, the treatment of choice is low molecular weight heparin or low molecular heparin is the treatment of choice. And coming to submassive, based on the condition of the patient, the clinical symptoms, the vitals, the stability of the patient, we can go ahead with thrombolysis and also low molecular weight heparin. Okay. In this case, the patient is having a massive pulmonary embolism since hypertension was present.
Why the patient develops hypertension in a pulmonary embolism? Pulmonary embolism is a problem in the lung blood vessels. Why the patient develops hypotension?
In massive pulmonary embolism, it is due to mainly occlusion of the pulmonary artery. The pulmonary artery gets occluded, that leads to RA-RV dilatation, then in turn pushes the septum and causes the LV chamber to be very small. That causes LV systolic dysfunction. That in turn causes.
So there are 2 important reasons. One is pulmonary arteries are obstructed. So when it is obstructed, blood will not go from the right ventricle to left atrium through the pulmonary circulation. That is a primary reason. Secondary reason is when there is enlargement of right ventricle, that pushes the septum to left ventricle side, and the size also will be restricted. So 2 reasons: one, left ventricle is not getting blood. Second one is the compression of left ventricle by the right ventricle septum. Okay, so 2 important reasons. Normally, suppose you don't have anything, how do you overcome this type of problem? It is not very easy to overcome. So what is the first line of treatment in emergency room for a patient who is having hypertension due to pulmonary embolism?
We can start on any inotropes, sir.
What is the treatment? First line of treatment. Bolus fluid is always the treatment. So bolus fluid advantage is it may push more fluid to the pulmonary circulation. It may go to the left ventricle. Sometimes when you are giving, patient may go to pulmonary edema also. That we cannot predict. But ideally you give more fluids, little more fluids. Watch the patient. Sometimes the blood may go to left ventricle and circulation will improve. Even if you start noradrenaline, it is not going to improve because left ventricle is not getting adequate blood. So even if you start dobutamine, noradrenaline, whatever drug, it will not, blood is not coming. So how can it increase the BP? So here only fluid challenge will be one option, most important option in emergency room. Okay.
So in this patient, we go ahead with thrombolysis. The indications of thrombolysis in pulmonary embolism is cardiac arrest in pulmonary embolism
and severe hypertension,
unstable pulmonary embolism, and you can see a large thrombus on imaging.
Is RV RA dilatation seen in all pulmonary embolism?
Not necessary.
Mostly in a massive pulmonary embolism only you get it. Otherwise you don't notice anything.
The contraindications for thrombolysis are any bleeding diathesis, any recent surgery within the last 14 days, GI bleeding within last 21 days, or any evidence of any cerebral hemorrhagic stroke.
Okay.
In those cases.
So after giving fluid, you are given fluid. Patient's BP is not increased. What is the next option? Hypertension management everywhere it is same. Give fluid, give inotropes, because emergency room we cannot do more than that. Give fluids, start inotropes. Whether it work or not, that is only secondary issue. But when the patient come to ER, we will not be knowing pulmonary embolism. Only after doing all investigation, you are coming to know that it is pulmonary embolism. But in any patient coming with hypertension, shock, you have to give fluids. Second line of resuscitation will be noradrenaline and then vasopressin. Okay, so that has to be done, and that will be done because we are not getting a proper diagnosis in most of the cases. Only rare cases like this you get S1QT3 T3. That is how much percentage you can get.
S1Q3 T3 is specific for pulmonary embolism, but it is seen only in 30%.
It is not a very common finding. It is a rare finding. Only in massive pulmonary embolism you get. What are the common ECG findings in pulmonary embolism?
We can see T inversions from V1 to V4. Any acute onset AF.
Most common finding is tachycardia.
Sinus tachycardia.
That is the most common one. Second thing can be like you told, there might be T inversion, atrial fibrillation can be there, RBVB can be there. They're all secondary findings. The most common ECG finding in pulmonary embolism is only tachycardia. Okay. Most common chest X-ray finding?
It can be normal.
Mostly chest X-rays are normal in pulmonary embolism, but sometimes you can get findings like oligemic lung, Hampton sum, so many findings.
Prominent pulmonary artery.
That can be there.
In this patient, we go ahead with thrombolysis with alteplase. The dose was 10 mg IV bolus followed by 90 mg over 2 hours.
Okay. What are the things you have to anticipate when you are thrombolizing a patient?
We need to look at first the indications and contraindications for thrombolysis, and we'll look to rule out the coagulation profile of the patients.
Okay.
We have.
Now, what are the conditions you can get pulmonary embolism? So you know how to manage, because most of the time we have to give with fluid with noradrenaline. Only in massive pulmonary embolism you thrombolize. Otherwise, all you give heparin or low molecular heparin, that is more than enough. And if patient cannot be thrombolized, then you have to take for thrombectomy. Okay, that should be taken to a cath lab, not in emergency room. Okay. So what are the conditions you get pulmonary embolism? That when you read about pulmonary embolism probable diagnosis criteria, you can know what are the conditions you get pulmonary embolism.
There can be inherited factors and also a
common thing first.
Prolonged sitting, surgery.
Okay. So somebody is having prolonged bed rest. The most important thing. Second thing, somebody is having a deep vein thrombosis. Then malignancies. Then patients are on drugs. Surgery, malignancies, trauma, hormonal therapies. These are the most common condition we see. Pregnancy is another condition. Then in diseases like SLE. That is very, very important. SLE, APLA syndrome. Then only that inherited conditions will come. What are the inherited conditions?
Factor V latent mutation, protein C and protein S deficiency, antithrombin 3 deficiency.
Okay. So protein C, protein S deficiency and antithrombin deficiency, can you do testing in acute phase?
Acute phase, no.
Acute phase, mostly they will be depleted. Protein C, protein S, antithrombin, everything will be utilized during acute phase. So if you are doing that test, you can document there is a deficiency, but it may not be correct because that is utilized. It is not because of deficiency. This protein C, protein S, all are utilized for self thrombolysis. So that acutely, if you do, you cannot brand the patient as protein C, protein S deficiency. That you have to keep in mind. And once the patient is stabilized, when you stop warfarin, then you can go for testing. So these are the common causes. Okay, what is the cause here?
Malignancy.
In malignancy, there are two important reasons for pulmonary embolism. What are the reasons? One is all malignancy conditions are prothrombotic state. Due to some changes in the body, patient can develop thrombosis. Second thing is the dislodgement of tumor cells to the blood vessels. From there it go. So two ways it can produce. So one is like your inherited conditions. There will be some coagulation defect, and that produces thrombosis inside the blood vessel. Other one is dislodgement of malignant small emboli can go to systemic circulation. So in a malignancy patient in the lower limb or lower abdomen, What else you can give? So repeatedly, if the patient is getting DVT, pulmonary embolism, what is the other treatment?
Prophylactic.
IVC filter can be kept. If somebody is incurable, not able to treat, he is having a lower area malignancy, continuously is throwing thrombus to the circulation, means we cannot treat it with heparin, because heparin or your drugs, other drugs like TPA, all this, they produce thrombolysis. Heparin prevents thrombus, that alteplase produces thrombolysis. Here in malignancy, sometimes malignant cells itself can produce a bolus and go to circulation. That cannot be treated with your drug. So in that type of condition, you'll have to keep a filter. Okay. So that is only in a chronic repeated thrombolysis. So after thrombolysis, what happened to this patient?
The patient gets better, sir. Then patient was in ICU for another 5 days. And we started the patient gradually on other oral anticoagulants. Since the patient was a malignancy with multiple meds, the patient was continued on anticoagulants. If there is any reason like surgery, trauma, then anticoagulation will be continued for only 3 to 6 months.
Okay, 6 months minimum you can continue, you can probably stop it. But if there is an incurable condition or congenital condition, then you have to treat for lifelong. Okay, protein C, protein S deficiency. There it can be either the deficiency can be acutely produced by the thrombus itself. So that's why in protein C, protein S deficiency, if you are documenting, you have to continue the treatment for 6 months, stop the drug, wait for 1 or 2 weeks, then recheck protein C, protein S deficiency. If that is still persisting, then the reason for thrombus is protein C, protein S deficiency. Then the lifelong he has to continue. Suppose it is reverting back to normal, then that is only produced by acute problem. So protein C, protein S deficiency is very important in emergency room, because if you wrongly write it as protein C, protein S deficiency, lifelong patient has to take this tablet. So better to document it as acutely, either don't do it, or when you are doing, you tell the patient after 6 months, you have to stop all the drugs like warfarin, then recheck the protein C, protein S. Okay, that has to be taken care by physician or rheumatologist. Okay, then
there are several scoring systems for pulmonary embolism. One is pulmonary embolism, the predictive scoring system based on 8 criteria, like age less than 50, heart rate more than 100, history of trauma, recent surgery, previous history of DVT or pulmonary embolism, unilateral lip swelling, hemoptysis, and oral hormonal therapy. If these 8 parameters are negative, then the chance of pulmonary embolism is nil. If any of them comes positive, then it is a predictor of pulmonary embolism.
okay.
And there are other criteria like pulmonary embolism severity index is there.
One condition will not be there here. Which condition you get antithrombin 3 deficiency normally in clinical practice? Antithrombin deficiency, you have read it is a congenital problem. That is the commonest thing given books. But in one condition, you get a lot of patients here where antithrombin 3 deficiency will be there. That is nephrotic syndrome. Okay, patient losing large amount of protein through urine. So all the proteins in body, your hemoglobin, thyroid globulin, everything will be lost through the urine. That type of patients are prone for thrombus episodes. Okay, that is because of the loss of antithrombin 3. So, but that will not be mostly will not be there in your books. Okay, books what says is the antithrombin 3 deficiency congenitally, but it is acquired condition. Okay, so that will not be there even in the scoring system.
And then the other scoring systems are pulmonary embolism severity index based on age, sex, and chronic episodes of pulmonary embolism, heart rate, systolic blood pressure less than 100, tachypnea, and altered saturation less than 90%. It is classified into 5 classes, and based on each the increased scoring system, the risk of mortality also increases.
Okay.
In this patient, the points was 190, and it predicts a high risk of mortality in this patient. The other 2 scoring systems we are used are the modified well scoring system. In the modified well scoring system, the history of DVT and also the alternative diagnosis of DVT less likely, those add for 3 points each. and also history of any heart rate more than 100 and surgery within the past 4 weeks and prior DVT or pulmonary embolism 1.5 points each, and hemoptysis and cancer treatment in the past 6 months 1 point each. And a total score of less than 4, the chance of pulmonary embolism is less likely, and more than 4, the chance of pulmonary embolism is more likely. And
if you have a DVT patient in emergency room, what precautions you take when you are examining the patient?
We would not press the
there are a lot of signs given in textbooks. You squeeze the calf muscle, you move the limbs. They're all completely wrong. If you are doing all these tests, there's a high chance of dislodgement of this thrombus and go to pulmonary embolism. So better to avoid all the physical examination. In a suspected DVT, you can do an ultrasound and rule out. Other tests are very good. They can pick up the lesion, but there is a chance of dislodgement. So better not to examine the limb at all. Look for any warmthness, any small tenderness, movement difficulty, all these things. That's all. Don't try to squeeze or move the limb like that.
The other scoring system was the revised Geneva scoring system that will predict the patients into low risk and moderate risk group. When a patient, if you are suspecting pulmonary embolism, initially we need to, on the clinical symptoms and the findings, low risk and moderate risk, severe, high risk group. In low risk group only, we will go ahead with D-dimer. Okay. In high risk group, D-dimer is of not value, we will go ahead with CT pulmonary angiogram.
So D-dimer is a test. We can negative, it can have a negative predictive. If D-dimer is negative, mostly pulmonary embolism is ruled out. Where all D-dimer can be positive?
Can be positive in MI, it can be positive in infection, sepsis.
Infection, infarction, MI, sepsis, everywhere it will be positive. Even in pulmonary like consolidation, pneumonia also, it can be positive. So there is, it will not, if it is positive, it has got no value. If it is negative, then your pulmonary embolism will be mostly ruled out. Okay.
The other methods of treatment is like starting on low molecular weight heparin, like enoxaparin can be started at 1.5 mg per kg, then overlap it with warfarin, then other newer anticoagulants and can be vitamin K agonist like warfarin.
Overlap with warfarin means warfarin is available nowadays. Warfarin is available for a long time. Newer drugs are available nowadays. Advantage of warfarin is very cheap. Disadvantage is frequent monitoring is required. INR monitoring is. So how do you start warfarin?
Start with low molecular weight heparin along with warfarin.
Along with. So it is always along with warfarin. So warfarin, heparin together, because warfarin takes minimum 7 days to get its peak action. So till then you continue heparin, then stop heparin, continue warfarin. Okay. So warfarin should be started from 10 milligram. Then you can slowly reduce the dose. Most of the time we start with the lower dose and hike up the dose. Ideal treatment plan is start with the higher dose and reduce the dose. Okay, so that can be done. So here this patient is put on newer drugs or warfarin?
Newer drugs.
Newer drugs. Okay. How long you will continue warfarin in this case? How long?
And in case of malignancy, so
mostly you have to continue lifelong, because till the malignancy is there, he is prone for thrombus. This one. Okay. Anything else is there?
Then the echo findings which can be seen is the McConnell sign.
McConnell sign.
Where there is hyperkinesia of the RV apex and hypokinesia of the free walls.
Okay. So that is also very important, but RA-RV dilatation is the most important clinical finding. Other things, if you can pick up, that is also good. And compression of the LV is also another important finding that will be clinically shown as hypotension. Okay. Anything else you want to tell? Nothing. Okay. Thank you.